Ladies and gentlemen, now we start the next session, chaired by Hiroshi Yotsuyanagi, Jidon Jia. Please start the session.
Good afternoon, everyone. Then we will start this afternoon session, viral hepatitis in patients with HIV. And I am Mr. Hiroshi Yotsuyanagi from Japan, and my colleagues are... Yes. Oh, he's there. And yes, I will chair this session with Professor Jen Jia. And I'm sorry, the first speaker, Professor Ara Edwin Ibrahim, has not come here and has not registered yet. So for now, we will plan to start two speakers. The first speaker, Professor Takeya Tsumi from the University of Tokyo, who specializes in viral hepatitis and HIV. Okay, Dr. Tsumi, please start.
Thank you, Chairperson. I also thank Dr. Shina and the organizers to give me an opportunity for the presentation here. Today, I'd like to talk about clinical features and vaccine efficacy of hepatitis A virus infection in HIV infection. I have no COI. There was an outbreak of hepatitis A in 2016 to 2018 in many countries, including Europe and Taiwan. Also in Japan, there was an outbreak of Hep A in 2018, and most of HIV-infected patients were men who have sex with men, MSM, including people living with HIV, PLWH. Based on these situations, CDC announced person-to-person outbreak of Hep A across the United States. According to a recent report, fatality rate is 0.10% and the hospitalization rate is 41 to 84%. And average cost per hospitalization is over $16,000. Before an outbreak of Hep A in Japan, my former colleague, Dr. Koibuchi, examined 354 MSM PLWH without previous Hep A vaccination for HAIZZ, and overall positive rate was 16.9%. This is the data in our study, and this is the data from another study showing the positive rate of healthy people in Japan. As you can see, the rate in PLWH was higher than healthy people, which increased with age. We also examined factors associated with HAIZZ positive and found that age and history of HBV, HCV, or syphilis infection is associated with HAIZZ positive, indicating Hep A may be a sexually transmitted disease. This is a similar study from Taiwan about the prevalence of HAIZZ in PLWH. They show that 21.2% were HAIZZ positive, and compared with HAIZZ negative, HAIZZ positive were older, and the history of HBV infection is more frequent. This is a red plot is the data in this study, and the blue plot is data from 10 years ago. That is the rate of HAIZZ positive by age. And as you can see, HIV seropositive was decreased from 60% to 21%, but rate in young age was increased from 3.8% to 8.5%. As I mentioned in previous slides, there was an outbreak in Japan in 2018, and our hospital experienced 11 patients in this outbreak. Also, in Japan, around 2000, there was an outbreak of Hep A, and in that time, we experienced 5 patients of Hep A with PLWH. Because recommendation on when to start HIV therapy was different between these periods, The latter cases had a better immunological status, such as CD4 cell count and the CD4 to CD8 ratio. Reflecting the better immunological status in the latter group has a higher transaminase levels, such as ALT and AST. We also examined the levels of HIV RNA in serum and also in stool. As you can see in this slide, in all of cases, the HIV RNA was detected 50 days after onset of symptoms, and in several cases after 100 days. In stool, HIV RNA was detected in stool in all cases after 100 days after the onset of symptoms. According to previous reports, in immunocompetent patients, the estimated median period of HIV detection in serum and stool was 42 and 60 days respectively, indicating that HIV viremia and excretion of HIV into stool may be prolonged in PLWH. This is a study from Japan about 20 years ago, comparing the HEPA between HIV and non-HIV. Serum viral HEPA viral titers, duration of HIV viremia was longer in HIV, about median 53 days, compared with non-HIV median 22 days. Also, levels of serum transaminase was lower in HIV, especially ALT was significantly lower in HIV. There is a review studies comparing the HEPA between HIV and non-HIV. Also in these review studies, AST and ALT levels were lower in HIV cases. On the other hand, there is a recent study from Italy showed that no difference between AST and ALT. One of the reasons for this is that all of these HIV patients were on therapy and biological and immunological control was good. Based on these situations, CDC recommends MSM to have a HEPA vaccination. This is a study examining the efficacy of HEPA vaccine for the prevention of HEPA infection from Taiwan. As you can see, HEPA vaccination greatly reduced the incidence of HEPA infection, including asymptomatic, also acute hepatitis A, HEPA. Also, syphilis infection is higher in HEPA infection groups. In the worldwide, as a HEPA vaccine, Hablix, Bacta, or Twinrix were generally used. But in Japan, we mainly use Amgen, inactivated vaccine without adjuvant. Generally, for this vaccine, 3 doses are recommended. But by twice injection, almost all of healthy people could achieve the seropositivity of HAIGZ. During or after an outbreak in Japan in 2018, we started to vaccinate MSM PLWH, whose HAIGZ was negative. This is the data of HAIGZ titers in 147 MSM PLWH without HAIGZ before vaccination after each dose. As you can see, HAIGZ positive was observed in 71% after second dose and 98.6% after the third dose. Because the rate after the second dose, efficacy rate after the second dose was lower compared with the healthy control, we examined the factors related to HAIGZ positive after second vaccination. As you can see, duration of EART and the CD4 cell count are associated with HAIGZ positive after second vaccination. This is a similar study about efficacy of HA vaccine for MSM PLWH from Taiwan. Finally, they found that HA-IgG positive was observed in 19.4%. Factors associated with serological response was age and CD4 count and HIV viral load, supporting our data. Therefore, good HIV control and subsequent upregulation of CD4 cell is important for the vaccine efficacy. There are several studies examining the efficacy of Hep A vaccine for MSL-PLWH. In a relatively recent studies, the efficacy is about between 80 to 19%. And the significant factors are age, HIV RNA, and the CD4 cell count by multivariate analysis. But compared with 2010 studies, the efficacy of Hep A vaccines was in 2000s, probably reflecting the status of HIV control. We also checked the maintenance of HA-IgG in MSM PLWH. 82 cases completed 3 doses of vaccine, and 69 cases were HA-IgG positive. Among them, 51 cases were tested for HA-IgG 2 years or later after the third dose, and finally, 46 were positive and 5 negative. By comparing 46 positive cases and 5 negative cases, B cell count is significantly increased in positive cases. We also checked the HA-IgG titers after each dose and found in positive cases, HA-IgG titers after both second dose and the third dose is higher, significantly higher in positive cases. Interestingly, in negative cases, the HA titers after the second dose was all negative. This is a similar study about the maintenance of HA-IgG in PLWH from Taiwan. The efficacy of Hep A vaccination is around 19%, and they compared the patients who converted from positive to negative and also maintained positive. And they found that BMI, lower BMI, and the lowest ever CD4 count, and the lower HIV viral load, and the combination of Hep A vaccine is a significant independent factors by multivariate analysis. Because maintenance of HA-IgG in PLWH is poor, the efficacy of revaccination is examined in Taiwan. HA-IgG negative cases after 4 weeks or later, including non-responders and seroconverters, were revaccinated with 1 dose or 2 doses. As you can see here, 2 doses is better than 1 dose, and the seroconverter has a better response than non-responders. Factors associated with good response is seroconverter versus non-responder, and also CD4 count at revaccination. This data indicating that revaccination may be useful, at least for seroconverter with good HIV control. I'd like to talk about a little bit about the Hep B vaccine in PLWH. This is our unpublished data. 31 PLWH without previous HBV infection were vaccinated with standard protocol, and HBs antibody positivity was observed in only 8 cases, 26%. This is a plot of HBs antibody titers of 8 PLWH with successful vaccination. As you can see, the maintenance of HBs antibody is very bad in all of cases. This is another study. This study also showed that 60% cases could obtain enough titers of HBs antibody after standard vaccination protocol. But as you can see, 30% lost HBs antibody after 1 year, and about 70% lost HBs antibody after 2 years. According to another study, 77% of healthcare personnel could keep HBs antibody until 10 to 21 years after standard vaccination in the United States. Therefore, acquisition and maintenance of HBs antibody is also poor for PLWH. This is a meta-analysis of 17 interventional studies, and overall response rate is 71.5%. By comparing the schedule, dose, and CD4 counts, 4 doses are better than 3 doses, and a double dose is better than standard dose, and the CD4 count, more than 100 CD4 count is better than less than 500 CD4 count. Conclusions. Clinical features of HepA in PLWH are different from those in non-HIV patients, such as transaminase levels and period of virus excretion. To protect HepA, vaccine is useful, but standard vaccination with HepA vaccine is less effective for PLWH. Control of HIV titers and subsequent recovery of CD4 cell count are associated with efficacy of HepA vaccine. Maintenance of HIV disease is poor for PLWH, and revaccination seems to be effective for the protection against HepA. Further studies are desirable to establish more efficient vaccine protocol of HepA as well as Hep B for PLWH. I acknowledge the members of Division of Infectious Disease, the Institute of Medical Science, the University of Tokyo, especially Michiko Koga, who mainly performed the study I presented here. Thank you for your attention.
Thank you very much, Professor Tsumi, for interesting and wonderful presentation. He first describes, yes, in Japan, we have 2 outbreaks of HIV infection among patients with HIV, 2010 and 2018. And he compares the clinical presentation of HepA, and next he describes the vaccine efficacy and durability of patients in HIV. Yes, this presentation is now open for discussion. So do you have any comments or questions? Yes,
I have a question.
please.
Thank you. So thank you for your excellent presentation. My question is not really specifically for this topic, but I would like to know, do you, in Japan, do you routinely vaccinate against hepatitis A in all adults, all children?
No. in Japan, HepA vaccine is not universal.
Okay.
So, but we recommend MSM who are at risk for HepA.
Mm-hmm.
And also travelers to developing countries.
Mm-hmm.
Not universal.
Okay, thank you.
Any other questions or comments? In Japan, Dr. Chen, in Japan, yes, when this outbreak happened, the ID doctors and hepatologists are eager to vaccinate HIV patients. Okay. So in my institution, for example, about 20% or 30% of the patients, yes, they have to cover the cost of vaccination by themselves.
Okay.
Yeah, so only 20 or 30% of the patients were vaccinated after the outbreak.
Okay, thank you. But in China, we routinely vaccinate for all children. For adults, of course, we also like maybe just you can have that vaccination, but you have to pay by yourself, so-called out-of-pocket money.
Yes.
Thank you.
Yes, other questions or comments? Dr. Wei, no questions or comments?
Yes.
And very nice talk. Thank you. And Japan is a very open and country, and also you have very beautiful and sightseeing. So therefore, you may have the many travel visitor from any other country. So therefore, maybe and bring some and the virus, hepatitis A virus coming. So any impact for this in the travel for HIV, hepatitis A outbreak? I'm clear? Not clear?
I'm sorry, I can't understand your question.
You know, and there are many in the travel visitor from different countries.
Yeah.
And here in Japan is no prevalence of HIV infection. However, the visitor from different countries maybe bring HIV coming. Yeah. So any impact for that?
Okay.
And otherwise,
Okay.
and you will go abroad to visit other country. So if the Japan, some society or government propose, suggesting, recommended HIV vaccine before traveling, go abroad.
Yeah, actually, so travelers who are going to the developing countries are recommended for Hep A vaccination. And the first question, about, the first comment about your inbound, is actually after the outbreak of COVID-19, and now there are many foreigners coming to Japan. So maybe I think there is a risk who brings the Hep A into Japan.
But you do not have that
but I don't know.
Okay. So how about outbound? Your Japanese go to other country.
Yeah, in case of
Give the vaccine, HIV vaccine.
At least to developing countries, so like Asia or Africa.
You will give the vaccine.
Yeah.
Yeah.
Okay.
I see.
Okay.
I will add some comments. And in this time outbreak, 2018, the first outbreak happened in Taiwan in 1 or 2 years ago. Then went to Europe and then come back to Japan. And so MSM travelers go to abroad and infected and come back to Japan. So yes, travel itself is a very big problem for such travelers. So we recommend MSMs to vaccinate when going abroad. Thank you.
Okay. Another one is for immunosuppressed population, immunosuppressed, such as transplant receptor, and for this kind of also bone marrow and transplant, for this kind of population, if the government or society recommended the HIV vaccine.
For whom?
For transplant, such as liver transplant, bone marrow transplant, kidney transplant, all these patients take immunosuppressive therapy. You give these patients HIV vaccination?
As far as I know, maybe there's no positive recommendation for transplant.
Okay.
Yeah, but
No.
yeah, no.
So do you have any case HIV infection in this kind of population?
In this kind means MSM?
Liver transplant, kidney transplant,
Compromised.
and other organ
Yeah,
transplant.
so if they were at risk for Hep A, maybe Hep A vaccine is recommended.
Yeah.
For
The question
example,
is-
MSM or something like that. So
Yeah, the question is the patients will take and will have immunoinhibitor. So therefore, maybe it's sensitive to HIV.
I think so too, yeah. But I'm afraid that the Hep A vaccine efficacy is actually good in that case, the transplant patients who are immunocompromised. So I don't know.
Okay, thank you.
Yes, thank you for your wonderful discussion. So this presentation is closing, and thank you, Professor Sumi.
Thank you.
Yes.
So now it's my great honor to invite Professor Lai Wei to give his talk. Professor Wei is a professor of medicine at the Tsinghua University, Tsinghua Chang'eng Memorial Hospital. He was the president of Chinese Society of Hepatology, and will be the president-elect of APASO. So next year, he will have the APASO in Beijing. Professor Wei, please.
Thank you, and Professor Jia, and thanks for your kind invitation. And also, once again, and thank you so much for organizing committee, invite me to come here, and also and the two chairmen, so thank you. My topic today, excuse me.
Some water.
Yeah. I already talked to the assistant.
Yeah, a bottle of water. They already prepared. Thank you.
This is water.
Yeah. Yes. The bottle is very nice, like a beer.
Ladies and gentlemen, and good afternoon. My topic today is co-infection of HCV and HIV control in China. This is my disclosure. And you know, and China has a low HIV/AIDS epidemic in the general population. However, the number of people who live with the HIV or AIDS and continue to increase. It is estimated that there were approximately 500,000 people who were infected with HIV by the end of 2014. We do not have much data for up to now. And at the end of June 2017, the number has changed, increased to 660,000, and also including 41% who already in AIDS and patients. And China is also one of the countries with the greatest number of the chronic HCV infection, with an estimated of the 9.8 million chronic HCV infection. So therefore, and based on HCV and HIV share similar transmission routes, co-infections are very common in people living with the HIV and AIDS. So co-infection of HIV and HCV is associated with long-term mortality and morbidity and mortality. HIV infection can accelerate the course of HCV infection. Meanwhile, an HCV infection also can accelerate the course of the HIV infection. And it motivates a fast progression to fibrosis and cirrhosis. Liver disease is the one of the most important non-AIDS cause of death in people who live with HIV and AIDS, and particularly in the era of anti-reversal transcription treatment. Therefore, AIDS and HIV is a special population for our elimination in future. So how about the prevalence? And firstly, let's look at the data of our global and best estimates of the prevalence of HCV and HIV co-infection in 4 population samples. And the population sample means, force means the general population, men who have sex with men, and people living with HIV, and the people who inject the drugs. And we can take the general population as a reference. So if you look at this paper, you can find, in addition, only one or very few countries with a few of the patients with the HIV infection. And AIDS, I mean co-infection of the HCV and HIV. And meanwhile, you can find in most of the Asia-Pacific countries, the prevalence of HCV and HIV co-infection is pretty low. And however, if you look at the men who have sex with the men, it seems increased for the prevalence and also including in some big countries, and also in China, also in Japan. And if you look at the people living with the HIV and how about the co-infection, then you can find also increased prevalence in Asia-Pacific regions, and more countries compared to the men who have the sex with men. So therefore, it's implied that men who have the sex with men and also the people with the HIV infection is different and transmission route in Asia-Pacific different countries. So at last, and if you look at the people who inject drugs, and it's pretty higher and for the HIV and HCV co-infection. So therefore, it's implied from this map, you can know the majority transmission route in Asia-Pacific regions for HIV and HCV co-infection is due to the drug and maybe due to their sharing needle. So how about the total number? And this picture and this table is pretty huge. Here I just pick up the very in the specific population and areas. And here, and I pick up the South and the Southeast Asia. Then we look at the total infected individuals, including people who inject drugs. Then we look at the HIV infected individuals and also the HCV co-infection. In all areas, I mean the South and the Southeast Asia, then you can find, if we compare with the other areas, and we just lower than Africa. However, it's more patients and more infection, and including HCV, HIV co-infection, as well as HIV infection is pretty high. And compared with the other areas, except for the Africa. And so if you take a calculation, then you can find the totally is the percentage in all areas for HIV and HCV co-infection is achieved to the end totally globally in 13%. So therefore, it's a serious situation for Asia-Pacific regions. So how about China? And there is the data, and this data using the national and HIV and the registration and free treatment program. In this database, then can look at the different area in China. How about the HIV prevalence? And I mean they use the anti-HCV in people living with the AIDS and the HIV and AIDS. So in different area, Northern China, Eastern China, Southern China, Central China, Northwest China, Southwest China, and multi-regions, you can find it's a little bit higher in North China and South China and Northwest China. However, a little bit lower in the Southwest China. And so therefore, and it's estimated HIV prevalence is achieved to 46% in people who living with HIV and AIDS. So how about the factors? What is associated with HIV and HCV co-infection? Also, we take the example from the global data. Then we can do comparison between the global data and the Asia data and China data. In this data, you can find the special population and the very high risk score for HCV and HIV co-infection in prison inmates. And in addition to this population, the next one is the men who have the sex with the men, and also the people who inject drugs. So therefore, globally, if you want to do something elimination and for HIV or HCV, then it's a very special and micro-elimination population. And also, and you can find in the men who have the sex with the men. And so how about in China? In China, we take some an example from the local areas survey, not for the nationwide. But they use the different data from the different area pickup, including and more than 10 in the area 10 province. You look at this table, then you can find that the factors associated with the HIV, HCV co-infection and occurred in the half infection due to the heterosexual contacts. It accounts for more than half. In addition to that, remaining 40% occurred to men who have the sex with men. So therefore, the sexual and maybe the important transmission rule in China, these areas. So what's the other impact? Other factors is the low education levels. If you look at the level of the education, then you can find here the 30% junior high school, and also meanwhile 20% in senior high school, and even may in the primary in the school or less. So therefore, the education is so important for and to understand, to realize, and for the HIV and HCV co-infection. Meanwhile, in China, if you want to do some microemulation and focus on this population, I mean, so have the multi and sex partner, and also the sexual worker, and also the men who have the men, is very important. So how about the long-term outcome? Here is the data. The data is conducted by Professor Zhang Fujie, and Professor Zhang using the national-wide retrospective observational cohort study from 2010 to 2011. And this program is the China National Free Anti-Retrovirus Treatment Program. And totally, they have 33,000 patients with HIV, and in which 18% have the HCV co-infection. Meanwhile, you also can find 8% participates and with the HBV and HIV co-infection. And of course, and we even have 3% have the triple infections. If you look at this picture, then you can find that the blue color curve indicated triple infection, and the red color indicated HCV, HIV co-infection, and the green one indicated HBV and HIV co-infection. The last, the deep blue, indicated HIV infection only. Then you can find here that during the follow-up, up to the 24 months, the all-cause mortality was higher in participants with triple infection. And the next one is the HCV co-infection, and then in those with HIV co-infection. And however, the HBV co-infection is also low in this population. So therefore, regarding the HIV, AIDS populations, and the HCV infection, it seems the more important compared with the HBV co-infection. In addition to the all-cause mortality, and let's look at the non-injury mortality. Actually, it's the same data. However, if you look at you also can find the triple infection, HCV, HIV co-infection has very important long-term outcome. So how about the treatment? We already have some treatment for this and the populations. And you look at this data, the good one is that you can find the triple infection, HCV, HIV infection, HBV, HIV co-infection. They have the treatment and for the antiretroviral therapy. And however, if you compare the different population, in this population, the treatment and the receipt accounts more and achieve to the 87%. And however, in this kind of treatment, kind of the population, the triple infection, the treatment only for 3 or 4 populations. And also you have the challenge, use needs the map to do analysis. I will talk later. And also, we already have some simplified HCV diagnosis and callback strategy in HIV after patient's care. And originally, they used the simple strategy that's callback in HCV and the population. Then they take this in their plan and take this in the strategy to HIV after patient's care. Actually, this is the lowest led in the pilot study to simplify HCV service delivery in HIV after patient clinic in Kunming. At the beginning, they do that in the phase 1 or phase 2 study. In the phase 1, they went to try from visitor to enter HCV detector, then if the positive, switch to HCV RNA test, and if positive, and switch to the HCV genotyping test, then give the patients the treatment. And then they also take the comparison, that is the phase 2, and they used the reflex testing and report. So if the patients take sample, they test the anti-HCV, HCV RNA, meanwhile, and the HCV genotyping all together. If the positive, just call patients back to give the patients the treatment. So therefore, let's look at the results and the comparison between the phase 1 or phase 2. Then you can find in the phase 2 strategy have the more patients have the anti-HCV and test. And the particular improvement in the anti-HCV positive, they test in the HCV RNA test. They can find significant between the 2 and strategy among this and the HIV after patient's care. Of course, HCV RNA in the positive patients was identified quickly and a high percentage. Of course, you give the treatment initiator and very quick and higher. However, compared to the NIS HCV RNA positive population, it's still low. And anyway, at the last, and the treatment SVR rate is pretty high in this reflex testing strategy. So therefore, it seems that reflex testing significantly increased HCV diagnosis and of efficiently improved HCV treatment. Also, it's improved HCV service delivery in HIV after patient's care. Another study is that among the HIV infection, maybe they have some newly HCV infection. I mean, in the people who with the HIV and AIDS maybe have the newly infection of the HCV. So therefore, in this retrospective study of recent acquired HCV infection in HIV after patients in the clinic, and you can find you find some patients totally here, and you show you the treatment strategy and treatment regimens and the HIV viral load. HCV genotyping you can find is complex 1, 3, 6, and also the HBV infection situations. So then you can find, regardless if the patient's anti-HCV elective, regardless in the symptom, and also you can test anti-HCV, HCV RNA, then switch to treatment, and also plus the combined treatment to HCV and also HIV. And there you can find the treatment for HCV, they have the very good results. HCV RNA undetectable, the SVR achieving to the 98%. So it's a very effective in this strategy, and also the safety is good in these populations. And you know, and there are some drug-drug interaction between the HCV treatment and the HIV treatment. However, in these populations, they adjust so the treatment can continue. So it seems regular screening and the prompt treatment is an effective strategy to prevention HCV infection, newly infection, and also HCV transmission in people who use the AIDS and HIV. However, some challenge remains. So what's the challenge? we see then this picture again. But here, I just want to focus on the patients of the lost to follow up. So you can find even some patients death, and however, still have some patients and lost to follow up. You can find here, and particularly I want to say in HIV and HCV and the population, it accounts for 47%. So therefore, it's challenging. We should improve the patient's compliance and provide and more closer and collaboration with the patients and provide the services to these kind of patients. Then you can give the patient treatment. So, and the other question is, if we look at this and other retrospective cohort study and conclude including and the 58,000 people living with HIV infection who initiated antiretroviral therapy, and then you can find, and in these populations for the treatment in HIV and also the co-infection is HCV, the treatment is pretty low compared to the total populations. So another challenge is that we still have the many HIV patients who have co-infection with HCV not have the treatment for an anti-HIV and anti-HCV. So ladies and gentlemen, I summarize here, we have a high burden of HCV co-infections in HIV positive populations. The incorporation of the comprehensive screening, treatment prevention, and the vaccination program into the general HIV management in China are imperative. Here, and vaccination means for HBV, not HCV, not HIV, because no vaccine for that. And meanwhile, screening for viral hepatitis is important in individuals, in people diagnosed as HIV positive. Effective management for viral hepatitis should be integrated into HIV treatment progress. Meanwhile, when we talk something for HCV infection elimination, the task sharing should be integrated with the HIV linkage care. And once again, and thank you. Also, particular welcome to Beijing. Next March, we will have the Apostle 2025 in Beijing. So welcome to Beijing. I look forward to have you in Beijing. Thank you.
Thank you, Professor Wei, for your very clear talk. Co-infection of HCV and HIV. I'm not an expert in the infectious disease.
I'm not an expert too. I'm
but you are. So, but this is a very, very interesting topic. Now it's open for discussion. You can have any comments or any question you like. Yes, good.
Hi, I am Tsutsumi from the University of Tokyo. Thank you for your great presentation. So you showed that the mortality rate of HIV and HCV co-infection was higher than HIV only. Maybe that is no treatment of HCV, right? And also you showed that the treatment of HCV is effective even with HIV. So my question is, what do you think if you treated the co-infection cases with HCV treatment? So the mortality rate is similar with HIV only or also higher than HIV only?
And thank you. It's a very good question. It actually is a long story in China. And you know, and the HIV come to China is due to the blood and product. And so the blood product only and have the HIV contaminated. So therefore, at the very beginning, the HIV infection alone, not HCV. Then HCV and infection came from the commercial donation for the blood, for blood donation. So therefore, it's different population at the very beginning. At the very beginning, the HIV infection came from the blood products, and the HCV patients infection came from the commercial blood donation. So they are separate at the very beginning. And so therefore, because of this, And in HCV infection population, it's difficult to find the HIV co-infection people. However, things change due to the sharing transmission route and also increased of the men who have the sex with the men. And then in HIV population, particularly in the drug user population, they have some in the HCV infection. So that's the reason why I talk something. Actually, when I search data, most of the data just came from the HIV infection population. So very low data, very less data on HCV co-infection. So therefore, and however, anyway, the HIV population, particularly is the men who have the sex with the men, and also the drug user, needs in the two kinds of the population for us to do the HCV elimination, micro-elimination populations. Right now, and the China government already give the free treatment to HIV infection. The HCV drug only covered by the insurance. So therefore, and we have to combine the HIV people, HIV treated people, HIV doctor, so then can do that together. And both Professor Jia and I, we are hepatologists. You know, in China, hepatologists and infectious disease physician and take care the liver disease patients. And meanwhile, infectious disease physician also take care HIV patients. We did not take the HIV patients. So, and for this micro-elimination strategy, we have to do something collaborate because we focus on HCV elimination, the collaboration with the infectious disease department, institution, and the doctor. So, thank you. Okay. And also we do that.
Okay, thank you.
And also, actually, we also collaborated with some and the patient and the organization, because the HIV patient organization, they know everything because it's a very special population. They always together. Thank you.
Okay, thank you. Another question.
Thank you. Thank you very much for your very interesting and very comprehensive report. My name is Thuy from Vietnam, and I'm an infectious disease doctor working on HIV and hepatitis as well. So I have one sharing and also questions to you. So we have the same problem as you share, and I briefly calculated and the prevalence of HCV co-infection, although the burden of hepatitis, morbidity and mortality in Vietnam among people living with PL-HIV is the same, almost the same. And at times, most deaths in the ART era in our HIV populations is, contributed to hepatitis co-infection. So recently we have a project supported by the Global Fund, and we were able to provide treatment for HCV and HIV co-infected patients, and more than 15,000 were enrolled, and our cure rate was about 95%, so very similar to yours. So my questions will be like that, before the Global Fund project, people with HIV are known with the co-infection, but the payment they could not access the treatment because the payment for HCV treatment is high in Vietnam, and insurance only covers about 50%. So my question to you is that, can you explain more about the mechanisms of the insurance or the cost for the software regimen, as well as the all kind of testing and the health insurance coverage for your HIV infected people? Thank you.
And thank you, firstly, and I really appreciate you sharing. It's very good. So please please give me your contact information after this session. I think we can invite to sharing in the next Apostle 2024 or 2025 in Beijing to discuss an elimination, how to do task sharing. And second one, I would like to answer your question is, in China, insurance is the basic policy for national health policy. So therefore, we have the different system. And one system is for the citizen. And second system is for the employee. And third one is for the rural areas. So therefore, they have the different coverage and the percentage. Anyway, it's very simple. And meanwhile, the cost is reduced and reduced. And since 2021, the government released the plan to eliminate HCV infection to achieve the 2030 goal called by WHO. So therefore, because of this, and they also do something planning in the to reduce for the cost of the HCV drug, and you also have some generic drug for HCV infection, so that will be more cheap. And meanwhile, the government asked the pharmaceutical to reduce the cost 10% every year. So maybe no one cost in the future. Thank you.
Thank you very much. It's very interesting to
please
learn.
Okay.
Yes, that the government made the price lowers every year by 10%.
Yeah,
So
every year.
we
10%,
may take that example. Thank you very much.
Thank you.
Thank you. Yes. Is there any question you want to have? Comment? Yeah.
So, Professor Jia, do you have any more information, please? You can add more.
No. You already give very comprehensive explanation. That's really, Chinese government try very hard to work with the pharmaceutical company, with the academic sector, or try very hard to reduce the price year by year by so-called government negotiation, or another called central procurement, or many different ways. But for HBV medication, almost nothing, much cheaper than water, than one bottle of water. But for HCV, slightly more expensive, but much better. So I fully agree with what Professor Wei explained.
Professor Jia lead us and also organize us to the proposal for how to coverage more patients, how to reduce the cost both in HBV and HCV. So maybe you have comments for that.
Yes, and cost and coverage of insurance is a very big problem, especially among patients with HIV. Because Professor Wei's presentation shows that 25% of the patients with HIV are infected also by HCV. The rate is very, very high. And one problem is that I think the reinfection of the patients. Yesterday, one of my patients visited my hospital, and they suffered. They received 12 weeks treatment with HIV. But after 4 months, he reinfected again. Such case might happen in other countries, including your countries. In Japan, first time the treatment fee is almost covered by the government. And the next time by the insurance. But starting insurance, it is necessary to evaluate if the patients are reinfected or not. If reinfected, it is very hard, the hurdle is very high to do treatment under insurance. So yes, one of the most important thing is that infection, only once you are covered by the government or the insurance. Next time you will pay for the fee, and the patients with HIV, HCV conviction, the progression of fibrosis is faster than just HCV, but anyway, sometimes such cases happens. That is one problem, I think.
Okay, thank you for your very, very good comment on this. Actually, one speaker hasn't come, so we have plenty of time. But already we have discussed what we would like. If we have no further question, we will close this session. It's really honor for me to chair this session with Professor Yatsu Yakasi. Now his expertise in infectious disease really very much fit today's topic. I hope in the future we can have more communication or even collaboration in these very important fields. Thank you very much for your attention.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you very much, the lecturers and moderators.